Etkin, we want to extend our gratitude to you for joining us again. Thank you for being here with us and for all the wonderful engagement from last webinar. For those of you joining us for the first time, we want to extend a warm welcome to our series. Thank you for joining us. My name is Elite Hassan. I'm a graduate student in disaster and emergency management, and I organized this event alongside Professor David Etkin, Dr. Olivier Rubin, and Dr. Sandy Smith. Our aim is to identify research priorities, share knowledge between practitioners and academics, and help build a better network for those involved in this field. Our series takes place every Wednesday right here on the same Zoom link and generally at this time. So we look forward to seeing you here every Wednesday from April to June. Please note that we will be recording. Our recordings will be available on our website under the Recordings tab. We are recording so those who missed our event can still see the series, and those interested may rewatch the series. Please rest assured, only our speaker and their presentations will be recorded, and your video will not appear in our recordings. Please also note that you will be muted for the duration of the presentation, but we encourage you to use the chat feature to ask questions and share your insights. We'll reflect on all your comments and questions during our Q&A period at the end and unmute anyone who has a question. Please take a look at our chat now for our website, where you can find our schedule and recordings, as well as the link to our Facebook discussion group. We want to keep the conversation going post-webinar, hear your thoughts, and allow you to reflect with a like-minded community. Today, we will be posting 2 discussion questions after Dr. Dalgo's presentation, which we would be delighted to hear your insights on. Please add yourself to our Facebook discussion forum using the link in the chat. We're looking forward to an incredible presentation today. Thank you all again for joining us. We'll now have Dr. Sandy Smith introducing our speaker for today.
I am delighted to be the one to introduce Dr. Austin Dalgo to you. As you read in his bio, he's the pediatric palliative care physician at Memphis-Le Bonheur Healthcare System and at the University of Tennessee Health Science Center. You also read, in addition to his medical degree, he has a master's in bioethics and health policy from Loyola University in Chicago. And he is the director for the Center for Bioethics and Health Equity at Le Bonheur Children's Hospital in Memphis, Tennessee. What you didn't read about is that Dr. Dalgo once walked a cheetah on a leash in Zambia. Who knew he would have such multi-talents, and that he continues to work on a partnership in Zambia with the University of Tennessee. He has a passion for health equity and things needed to live a full life. I welcome you and thank you so much again, Austin, for sharing with us from your vast wealth of knowledge about health and ethics.
Thank you, Dr. Smith, and I appreciate the introduction. And you may have talked me up a little bit more than I'm able to live up to, but I'll do my best. I really appreciate this opportunity. I would like to thank Dr. Etkin and Elite for working with me and helping me to organize and to get my technology skills up to par prior to this presentation. And so I want to just take a little bit of time today to think about COVID, the distribution of COVID disease and vaccinations, and what the disparities are related to that. And then also, what are the ethics associated with these actions that we have taken and with these realities that we face in the world right now. And what I'm going to do is I'm going to talk about those disparities at the beginning just to get a lay of the land. I'm guessing many of us have actually heard about this already on the news, but just wanted to get us all on the same page. And then I'm going to talk about the ethical systems that we have used during the pandemic to help us either justify the things that we're doing or to guide us toward the things that we want to accomplish. And then I'm also not just going to look at what we've said, but what we've actually done as a society and as a globe, and whether or not those actions are consistent with or not consistent with the ethical systems that we've espoused. And then finally, at the end, I'm going to offer a quote new ethical system. This is not at all a new ethical system. It's one that's been around for quite some time, but I'm guessing many of us haven't heard of it. I went to seminary for 2 years prior to medical school, and so I'm going to borrow from some of my theological training for this new ethical system. So first of all, let's talk about COVID disparities both in the U.S. and globally. And so I'm going to start out with the U.S. and then kind of expand out to the globe after that. So this is a bar graph basically showing that that white Americans and Asian Americans have had the lowest case rate of COVID compared to essentially all of the historically marginalized and discriminated folks in the United States. So Black Americans, Hispanic Americans, Native Hawaiians, Pacific Islanders, and Native Americans have all had a significantly higher case rate of COVID than those who are more well off. And so really what this shows again is the idea that it's not just individual choices that are being made, but there's clearly patterns in the United States of this historical racism and historical marginalization in the US, and you see the results of that in this current pandemic. There's not just disparities in case rates, there's also disparities in deaths. So regardless of the age, Black Americans and Hispanic Americans have a significantly higher rate of death from COVID than white Americans. And so if you look on this x-axis, this is the amount of times greater these groups have a risk for death than white Americans. And so this is again just another just stark illustration of COVID disparities here in our country. And then finally, COVID vaccination rates in the U.S. So what's interesting here is that if you think right now, white Americans are the least likely to get vaccinated than any other racialized group. And so, but what you see that I think is really fascinating in this is the early uptake of the vaccine by white Americans and the very slow uptake by Hispanic and Black Americans. And so what this illustrates to me is the allocation, the decision-making of where to set up vaccine sites, how to access vaccine sites, were all favoring white Americans in the beginning. And only as time has gone on and more access has been granted and potentially more education and more trust has been developed, have Hispanic and Black Americans been more willing to get it. And you actually see that Hispanic Americans now are more likely to get the vaccine than white Americans. And so this reflects politics. This reflects access to the vaccine sites. And it also affects, it reflects the history of the United States in terms of research abuses and the mistrust that many African Americans feel of the medical system. So just fascinating numbers to think about, and really quite sad numbers to think about in terms of disparities in the US. And there's not just biological effects of catching the disease or of dying or getting the vaccine, but as we know, there's been biosocial effects. In other words, the highest rate of unemployment in the United States since we've been counting it was in April 2020. And studies have shown that Black Americans and Hispanic Americans are much more likely to experience economic challenges than white Americans. In fact, the number was slightly under half of Black and Hispanic Americans said that they have experienced economic challenges during the pandemic, whereas only 21% of white Americans have said that. We also know that education has been significantly affected, that low-income families and low-income children have had difficulty accessing their virtual school, and as well as lower test scores across the board, regardless of income. But education has been affected, nutrition has been affected, higher rates of food insecurity, higher rates of malnutrition during the pandemic, both in the United States and globally, and then significant mental health concerns. Many people have talked about the second pandemic coming through after COVID, which is really a pandemic or an epidemic of depression and of anxiety because of the multifactorial effect of COVID, lockdowns, of isolation on folks' mental health. And we know that studies have shown that that has significantly affected women more than men, and minorities here in the United States more than white folks. And so there have been significant effects, not just in our health, but also in our overall well-being, financially and mentally. So zooming out now to the globe, I got these numbers April 11th, so a couple days ago. And there have been almost 5 million cases in the United States, at least that in the world, at least that we've counted. And there have been about 6 million deaths that we've counted. And so, this is quite staggering. When I was talking to a friend about this recently, and we have to also keep this in perspective. The COVID pandemic has been horrible and awful and has killed many people. But when we look back 100 years ago, the numbers are sketchy, as we all know from 100 years ago. But it's possible that up to a third of the world's population died in the influenza pandemic of 1918 to 1920. And so, in fact, this has been awful. But we're doing a lot better than we did 100 years ago. And we can credit ourselves and we can credit science for that improvement. But we also have a long way to go. And so what I also want to point out here is if you look at the size of the dots, that's the number of cases, the number of cumulative deaths. And what you see here is that high income and middle income countries have the biggest dots out of all of the places in the world. And I want to ask that question to the group, and maybe we can talk about this at the end. I'm not going to answer it right now, but consider for yourself, why are the cases and deaths higher in middle and high income countries compared to low and middle income countries? This seems to be reversing the trend of what I'm talking about right now, which is disparities. It seems like what would make sense, according to all of the other diseases and conditions that are worse in low and low income countries. Why is it that COVID has been worse in high and middle income countries? So just something to think about. This is the kind of graph that you see, or the kind of picture that you see for malaria, for tuberculosis, for early death. For many of these conditions that we see across the world, we see disparities. We see that the high income countries like the global north and the global west tend to be doing a lot better. And so the dark orange is countries that have a higher access to the vaccine, and the pale yellows are countries that have lower access. And so what we see here is a significant gap in the middle of the globe here, which is the continent of Africa, and very little access to the vaccine. And this is not just geographic, but this is also income based. So the poorest countries of the world have access to the 20%. I'm sorry, let me say that again. The least wealthy 50 places in the world have access to 8.1% of the vaccines, but they have 20.6% of the world's population. So what that means is that there's a difference here, that the poorer you are, the less you have access to the vaccine. When I did this talk back in November, or at least a part of this talk, I took this graph and the number was actually significantly lower, close to about 5.8%. For the 20% of the world's population. So we're actually getting better, but that's that kind of graph that we saw in the United States, where the well-off have access early, and the not so well-off are get it later. And so again, this is allocation by income, not allocation by equity. And so globally, we talked about the biosocial effects in the U.S. We also see that globally, that 1.6 billion children are going to be out of school due to COVID because of their lack of access to technologies to be able to do virtual school. As a parent who was a partner in doing virtual school with my wife, virtual school is not ideal either. And we can all attest to that from our own mental health, or some of us can from our own mental health from that process. But imagine those who are not even able to access virtual school. There's also been less investment. There's going to be less investment in clean energy sources. So as Dr. Etkin talked about environmentalism last week, and in sort of extending ourselves beyond what the globe can take, we're investing less in the climate. Additionally, we're going to add about 250 million people who are going to be pushed into poverty by 2030 because of the pandemic. So this is not just an effect on people's physical well-being again, but also their biological and their social well-being. So that's the lay of the land. So what have been the ethical systems that we have used in the pandemic and from 2019 to 2022 to say this is how we should operate and this is how we should handle ourselves? And I'm going to go ahead and say at the very beginning, I am part of that system, what we have said. So the main ethical framework that we use is consequentialism, which is really what triage ethics is based off of. And what we're trying to do in consequentialism is really save the most lives that we can with the least amount of money and in the most fair way possible. So that sounds like a great ethical framework, right? Save more lives, do it cheaply, do it equitably. That is good. And it's often the foundation for public health and for triage ethics. And so this is a quite useful framework. But people have said, well, if we only think about how to do the most good for the most number, we might be leaving some people behind here. And so a response to that, and a response to actually John Rawls and his sort of very individually focused ethical system of justice is communitarianism, which is the idea that people are not just individuals, but we're actually more molded by our community in our group than we are just solo functioning individuals. And so one framework has been, why don't we focus on particular communities that are going to benefit, and that can be our focus on how to distribute risk and how to distribute benefit and during the COVID pandemic. Another really interesting ethical framework is narrative ethics. And this goes back to the wicked problem that Dr. Etkin was talking about last week as well. Narrative ethics says we can't know the ethics of a situation unless we know where people are coming from all sides of the perspective. And so unless we collect people's stories and know people's stories about how the COVID pandemic is affecting them personally, we're not going to be able to make the right decisions and make the right policies. And so we have to understand this many-sided diamond of this story of the pandemic. I wouldn't call the pandemic a diamond. That's probably a bad way to say it. But we need to understand all the facets of the pandemic from very different perspectives. I think that that's really good. What has ended up happening is that narrative ethics has turned into storytelling competition. And we have essentially turned it into a culture war of who's getting hurt and who's benefiting. And instead of really trying to be that philosopher poet that Dr. Etkin talked about last week, where we're really trying to understand the deeper meaning of the decisions we're making and understand people's stories. And then finally, in the global health world, we've talked a lot about distributive justice. Essentially what that means is that we really want resources to be distributed in the fairest possible way. And it's not just in the fairest possible way, but also where they need it most. And so, for example, if the pandemic is raging in India like it was during the Delta variant, maybe we should be allocating more resources to India rather than stockpiling resources in high-income countries where Delta is not quite as severe. So those are the frameworks. What are the principles behind those frameworks that we have espoused as a society? Well, all of these are really important, right? We want to minimize harm. We want to increase the good. We want to proportionally give our resources to the places that need it. And so we've talked about allocating ventilators in the right way. We want to talk about being together, because a pandemic doesn't just affect individuals, it affects communities. And we've talked about reciprocity. It's not just the emergency management folks that have a duty to care. They do have that, but also society has a duty back to these professionals and back to each other to protect each other and to wear masks or to get vaccinated. And so these have been concepts that we've debated and talked about extensively. And we've also talked about some procedural values, not just how we should act, but also what are the procedures we should use. And so we've talked about what are some reasonable policies? How can we be transparent in this when we're developing, for example, ventilator allocation policies or vaccine rollouts? Who do we prioritize, and how have we made that decision? And the truth is, there have been some very good examples of transparency and some not very good examples. And so we've seen in some countries where there's really obfuscation of the data. In Zambia, where I've worked, there was a study published in JAMA that talked about a significant number of people who have died who were undiagnosed with COVID. And it was, if I remember correctly, it's about 15 to 20% of people were COVID positive when they tested people in the morgue. Whereas the Zambian sort of party line was that there was almost no COVID in the country. And so that study showed that there was probably not as much accountability going on as should have been. So those are the principles and procedures that we have espoused during this pandemic, which I think in many ways are very good. But what we've seen also is that the actions that we have taken have not always agreed with those principles and those frameworks. So one is that we've seen I think contradistinction or contrary to the idea of fairness, is that we have seen people we've seen certain people do much worse during the pandemic, even if they don't have COVID, than other people. And we talked about this with race in the United States, as well as the differential across countries. But we've seen people with chronic diseases have worsening outcomes. So people not able to access their primary care doctor, or people afraid to access their primary care doctor. And the only way that they can is telehealth, and they don't have internet at home. We've seen that people who have low income jobs or are working in the service industry lose their jobs much faster. We've seen people feel isolated and alone during this. We've seen people have decreased cancer screening. So cervical, breast cancer, colon cancer screening has gone down by 50% in the last couple of years because people just are not coming to the doctor to get screened. What about caregivers of people who have dementia, or people who, or just anybody with chronic medical illnesses? What about those caregivers? They feel very isolated as well. Their mental health has struggled. So we've seen that the COVID pandemic has affected some people more than others, and our society is not structured to help these people and to move beyond that. We've also seen increased mortality in dementia, partly because of long-term care facilities in the pandemic reaching those areas very early, but also just the isolation and being at home all the time leads to worsening outcomes as well. We've also seen in our actions that when I was part of writing the ventilator allocation strategies for our healthcare system, and if we got to the point where we didn't have enough ventilators, what would we do? And there were a number of things that we talked about that I think are really important to consider in terms of the actions that we're taking. One, we have often prioritized healthcare workers in our ventilation allocation strategies. In other words, if a healthcare worker comes in and is sick, do we prioritize them over, for example, somebody who's not a healthcare worker? And I think that's an important question to consider, because the healthcare workers are obviously people who are saving lives in their regular job and are hopefully going to come back and do the same thing. So maybe we should prioritize those people. But the question then became, who do we prioritize in the healthcare industry? Is it just the doctors, just the nurses? Do we also prioritize environmental service workers or respiratory therapists? Who are the healthcare workers that we're prioritizing? And are we doing that potentially based on a hierarchy of folks in the healthcare system? Because we need environmental services workers to clean rooms and to help us with those particular things. We have also counted points off the allocation system for people with chronic conditions. And we know that people with chronic conditions are folks who oftentimes are less well off economically. And so what we have done in our allocation strategies is basically built in inequities in terms of, in the United States, race, but also income as well. And so we've seen that. And also the SOFA score, which stands for Sequential Organ Failure Assessment. And this is really a scoring system in the ICU to say really how sick somebody is, the severity of illness. And again, this is significantly affected by people's chronic conditions. And so we have chosen in our allocation strategies essentially to prioritize younger people, people who work certain jobs, and oftentimes people in the majority culture. And so one strategy that the University of Pittsburgh had actually was doing a zip code correction. And so in the United States, because of redlining in the 1930s and 40s, many marginalized people live in specific zip codes. And so they decided to add a point on, essentially to give them a better score based on the zip code that they live in. And so this was a way to try to correct some of these inequalities already baked into these allocation strategies. And then finally, just to add to that, in April 2020, a number of ethicists and internal medicine doctors concluded that policies, not many centers had developed a policy at this point, which our system had, but there was significant heterogeneity across the country, and that many of these omitted guidance on fair implementation of this policy. And so I think that that's really important to consider in really asking the question, did we live up to the principles that we said that we believed? And then finally, vaccine nationalism, and I think probably a lot of people have heard about this, was the idea that some countries were hoarding vaccines while other countries had no access. So at some point a few months ago, there was this sinister symmetry between the United States and the continent of Africa. The US had about 1 billion vaccines stockpiled and about 330 million people in our country, whereas the continent of Africa has about 1 billion people, 1.2, and they only had access to about 300 million vaccines. And so there was this sense that that high-income countries were keeping vaccines to themselves and not sharing them abroad. And we know that there are significant impacts of this vaccine nationalism, social, in that there's clearly this idea that some people are prioritized over others. There's economic impact. If the pandemic continues to rage across the world, we're all going to suffer economic impact. We're all connected. And then there's a biological impact. More variants are going to be created through a lack of vaccination across the world. So the pandemic, it won't end here unless it ends everywhere. And so COVAX was formed at the very beginning of the pandemic to say, let's allocate vaccines equitably across low and high income countries. And this was, countries could essentially buy into this. And high income countries did it as an insurance policy in case their vaccine strategy didn't work. And low and middle income countries did it because they wouldn't be able to afford the vaccine without COVAX. And the agreement was, we're not going to go past vaccinating 20% of the population until all countries in this COVAX consortium were vaccinated up to 20%, and then move beyond that. And so this was a great idea, and still many low and middle income countries have had access to the vaccine because of COVAX. but we certainly didn't live up to that 20% equity standard where we're going to make sure to distribute it across the world until everybody gets access. And so this was a moderate success, but certainly we didn't live up to that maxim that we said at the very beginning. We want to do the things that are going to save the most lives. Really what we did was we said we're going to save the most lives of the people who are most important to us in this moment. And oftentimes that revolved around our own country and people who look like us. And obviously I know I'm using the word us in a very vague way, but really in the United States, it's people who consider themselves white. So we've had a lot of great principles. We haven't really lived up to those principles. We have in some ways, but we also have failed in some ways. So is there a new way we can think about this? Is there a new ethical system that is going to get us to a different point? So I'm going to go back to my theological training, and Gustavo Gutierrez is a very famous Latin American theologian who is thought of as the father of liberation theology. Liberation theology really focuses on a couple of really important ideas. One is the idea that structures create violence. In other words, the policies in the environment that we live in keep some people from obtaining their basic needs, whereas it allows other people to have their basic needs. In other words, and so what Gustavo Gutierrez says, we need to focus as a church, as a society, on addressing the violence that are built into the structures that we have created. One example of that, as I've mentioned already, is redlining in the United States, really excluding African Americans in the United States from adequate housing. Liberation theology also talks about liberation of the oppressed and a preferential option for the poor. Really what that means is that society should focus its efforts not on the most cost-effective measure, not on making sure that people who are well off get the resources that they need. The assumption is people who are well off are going to get the resources they need. But it says we should focus our resources on the poor. Why? Because that's where the most need is. And as emergency management professionals and as medical professionals, I often think, where are the resources needed the most? The ICU is a perfect example of that. We created the ICU because those patients need the most resources medically. And so why not do that on a societal level? Why don't we create ICUs where there is a high concentration of poor and really poor resources into those areas? But it's not just this sort of standoffish concept where liberation theologians critique society and then step back, but it's really about pragmatic solidarity, living with the poor, accompanying the poor in their suffering. And so this is they focus on praxis, which means how do you apply these concepts to your daily life? So it doesn't let people off the hook of just thinking about these critiques, but it also asks the question is, how are you living this pragmatic solidarity with the poor? And so I think that we should shift our focus from consequentialism to restorative justice. Don't just think about what the most efficient thing to do is, but think about how do we restore fairness to the world? How do we make sure that the continent of Africa doesn't get left behind as it has many times in healthcare interventions? How do we make sure that the people in our own communities who are marginalized don't get left behind? Instead of thinking about just cost effectiveness, let's think about how do we distribute resources fairly? Instead of just coordinating from the top down, why not accompany the poor? Why not get in their communities and live in their communities? And compassion means suffering with. So not just feeling empathy for, but actually accompanying people in their suffering. And then finally going from a hierarchical approach to a more I'm sorry, egalitarian approach. Let's just say that, since I can't say that word right now. And so, so I think right now in the pandemic, we have focused on the left side of these equations and not on the right side of these equations. And I think that we liberation theology actually gives us the tools to shift that focus. And so finally, in conclusion, I think first of all, on a positive note, we already have the tools to accomplish this, to move into this new ethical system, because medical ethics and Dr. Smith last week talked about the ethical statements that are coming out by the emergency medicine professionals that she's working on. And we have the tools to really change the way we think about things. And we also have the tools through organizational ethics. So my own organization, Methodist Le Bonheur, has a wonderful mission statement. And my job as an ethicist is to say, are we living up to our mission statement? Are we doing the things that we say we care about? And really to push organizations to that. And I think by and large, organizations want to do that. And sometimes we just need reminders. And I think that the main issue right now is that we don't have the will to do it as a society. We see these ethical principles, we have these ethical principles, but we're not living up to it. And why? It's not that we don't have the tools, it's not that we don't have the resources, it's that we don't have the will. And I think that part of our job as professionals here is to increase that will, to speak about it and to write about it. And I will say, this is swimming upstream. This is not easy, and there will be resistance. And so I'm just encouraging you right now, keep swimming upstream. The arc of history is long, but it bends towards justice. And so finally, I want to leave you with a Paul Farmer quote, who's one of my heroes, who recently passed away. If access to healthcare is considered a human right, who is considered human enough to have that right? Thank you very much. I am open and willing for questions and comments.
Thank you so much. I really appreciate it. And I appreciate you following through with your promise that you would share with us a photograph of you walking a cheetah on a leash. And your children are just precious, as I would expect them to be. I want to encourage anyone, feel free to turn on your video or raise a hand if you would like to ask a question directly, or put it directly into the chat if you would like to do so. I'm going to begin with a question I just had. COVAX, is it still in operation? Mm-hmm. Is there anything that we need to do from those of us who are in the richer countries to try to encourage more distribution more equitably?
Yeah, so COVAX is still in operation, and it's really a consortium between a number of organizations. Gavi and UNICEF and CEPI are all big parts of that. And yes, the U.S. and other high-income countries are still distributing vaccines across the world. And what I'll say is that in many countries, it would be political suicide to distribute a large number of vaccines to other countries. I think oftentimes voters are looking for the reassurances that their politicians are making sure that they're protected. The question of equality across the globe is not as a high priority, I think, at least for US voters, as it is, I think, for others. So President Biden has, so the US originally was not part of COVAX during the Trump administration, and then did join COVAX during the Biden administration. And President Biden has distributed some vaccines across the world, but it's been a pretty low number. And actually, Paul Farmer and a number of other physicians and in groups wrote a letter to President Biden saying that it is unjust and unethical to continue to hoard vaccines at the expense of low and middle income countries. And there was about 150 medical organizations that signed that letter to the president, and it made the news. And I'm not sure how much of an effect that letter actually had, but it certainly put some pressure on the Biden administration to ramp that up.
Thank you. Another question is, what is the relationship between trust and ethic in all these? And the person who wrote it said, thank you.
Yeah, so I think that trust is absolutely important. And I think actually liberation theology has a significant amount to say about that. And I say that because some of the main precepts of pragmatic solidarity and accompaniment mean that you are next to the person that you're working with that's suffering. And so the word accompaniment comes from the Latin root pan, which means to break bread. And so the idea that liberation theology has is that you're sitting with those who are suffering, you're breaking bread with them, you're walking with them in their suffering until they tell you, I have reached the goal I want to reach. And so I think trust is developed when you walk alongside somebody else. And that is a very individualistic approach. I totally admit that. But I think that accompaniment can be part of our policy as well. I think that we can say, instead of, for example, when we distribute vaccines as high income countries, oftentimes we come in, we fly in, we set up these tents, we throw our UN logo on it, and then people come and they're like, why would I trust the United Nations? Why would I trust the University of Tennessee in South Memphis? They haven't done anything for me that I can recognize, and I can actually name some abuses here. And so if we were to say instead, we're going to accompany those who suffer, maybe we're going to distribute vaccines to local providers. Maybe instead of these sort of huge vertical programs that really fly in and fly out. And so we actually saw the success of that in the 70s when we did the smallpox vaccine. World Health Organization leaders worked with local healers, and they weren't even medical providers, they were local healers to distribute the vaccine. And instead, in malaria, when we tried to eradicate malaria in the 70s, we decided instead to come in and spray DDT on everybody's houses and invade people's homes, and didn't ask really the communities at all what they wanted. And so I think we have great examples that when you accompany people even on a national level, on an international level, that works better than these top-down hierarchical approaches. We also have to acknowledge past sins as well. I think that's a big part. That's like the minimum amount with trust, is to acknowledge that we've screwed up in the past as well.
Thank you. We have two questions that deal with the ethical framework. I'm going to begin with the one beneath. Do you think that the ethical framework in COVID was influenced in early days when we thought COVID would end faster? And now that COVID seems to be longer, endemic and sustained virus, that this is now causing the need to rethink a new ethical approach, which is more egalitarian?
Yeah, that's a great point. And I think that's absolutely right. I think in the beginning, when we're having this sort of panic reaction, the question is, how do we stay above water, and how do we stay afloat? And really the framework was like a lot like emergency methods, ethics and triage ethics. Like, let's save the people we can save. If you're too sick to be saved, or if you're too well to need the care, then we're not gonna worry too much about you. But if you're sick enough to allocate these resources, then that's what we're going to do. And that's a very consequentialist approach. And we focused on that. And I think what's fascinating to me, and that I thought about quite a bit during this, was that we thought about that in the United States, of how do we allocate these scarce resources? But then we didn't take a step back and realize, low and middle income countries have been thinking about allocating scarce resources for decades. And so instead of actually asking how are you doing this? How are you allocating resources over the last 20, 30 years because of scarcity? We just essentially buckled down and said, we're going to take this consequentialist approach. And so I think that that's absolutely true, that when we early in the pandemic, we used this approach, and then now we need to think about it differently. I think what's interesting too is that we were set up at the very beginning for there to be significant disparities in outcome. And so if you start out with an unequal society, even if you try to, you're still going to end up with unequal outcomes. And so the example of that is, let's assume I have 6 M&Ms and I give you 3 and your friend 3, that's equal, right? But if you're starting out with 5 and they're starting out with 3, then we're still ending up with an unequal outcome. And so the right way to do it, which is preferential option for the poor, I think, is to give you 2 because you'll have 7 then, and to give your friend 4 because then they'll also have 7. But instead, we have decided to do the 3 and 3 option in terms of our ventilator allocation protocols and also the vaccine allocation strategies.
Thank you. Another question is, how do you see the degree of politicalization of the pandemic affecting the ethical frameworks used?
Yeah. Well, I remember the director of the WHO, Dr. Tedros, said at the very beginning, if you politicize the pandemic, then people are going to die as a result of that. And I think we've definitely seen that happen. I think that liberation theology is very honest that it is a political movement. And so I think that it's hard to get out of, you can't get out of politics. Politics is not something we should try to avoid. Politics is something that we should try to bring into the light. That transparency that I talked about earlier is a really important part of that. And so, so I think that that we have, so the difference between equality and equity is simply the idea of everybody gets the same thing, then people who start out as more well off are going to be standing on a higher, standing at a higher level than those who are less well off. And equity says we need to give the people who are less well off a little bit more help so that they can stand at the same level of those who are well off. And so I think that statement itself is a political statement. And I think that we have to ask the question, as Dr. Etkin even mentioned last week, what kind of society do we want to be? Do we want to be a society that focuses on individual rights and what I want as a person, myself, or do we want to focus more on the community, and do we want to focus on people kind of having similar outcomes? In my mind, if in Memphis, Tennessee, life expectancy in South Memphis is 68 years and life expectancy in East Memphis is 81 years, I consider that a not good society to live in. And so I think that moving from individual rights to more egalitarian and humanity, I can't say that word. I said it right the first time and then I messed up the last. More egalitarian options is the right move. But again, I'm admitting that that's a political statement, but I'm happy to live in that.
Thank you. Another comment was, this is a wonderful presentation. Thank you, Dr. Dalgo, for sharing. It certainly raises a lot of questions and makes one look inside and examine our own approach. That said, in your opinion, why are we not using the tools we have?
I think we're not using the tools we have because it's swimming upstream, because it's harder to do accompaniment, and it's harder to do pragmatic solidarity than it is to keep the status quo. I think that when people are in power, they want to keep that. That's a positive feeling, and it's hard to want to redistribute those things once you have what you have. And we see that we see that across history. This is certainly a race thing in the United States, but it's true across the world. Once an oppressed group comes to power, they become the oppressor. And so we all want to get what we think is owed us. And instead, liberation theology, in my mind, frees us from the violent cycle, and frees us from hoarding resources, and allows us to say what we want is not to create violence by the structures that we live in. And so I think that giving up a privilege is a major reason why we're not using the tools that we have, because it's hard to use your privilege for the sake of others. It's a lot easier to do it for comfort for our own selves. And that's true on an individual level, but it's also true on a societal level as well.
Thank you. Dr. Dalgo, what are your thoughts on Switzerland removing all COVID protocols? Switzerland removed all COVID restrictions on April 1st, 2022.
Thank you for that question. I think that right now, I was talking with the same friend that I mentioned in the talk, and we were talking about how the CDC was criticized for confusing messaging throughout the pandemic. And I certainly think a lot of that is legitimate criticism. I also think, though, that it's difficult for the public in general to accept changing guidelines. I think that people say, you just changed it from this to that, why is it this? And people want explanations. But I think what we want a lot of times is just some normalcy and everything being the same. And so I don't know the numbers in Switzerland right now, but I think if the numbers are low and things are looking pretty decent in terms of deaths, then I think that's absolutely reasonable. I think we have to think about the social aspects of what the lockdown means. We're seeing that in Shanghai right now, and people essentially screaming out of their windows saying, "I'm starving," because of because of just the total lockdown. And I know that those are two extremes, but we can't forget about the effects that it has on people's mental health when we have these restrictions. Even masking, I miss people's faces. And so I think I think that has a mental health aspect as well. So if Switzerland's numbers are down, I'm going to celebrate it, and let's go to some concerts and have some fun and enjoy the culture, enjoy the world. So.
Anyone else? Are there other questions? If so, please raise your hand or put it in the chat. We have just a few more minutes together. There were several who had asked for your quote from Paul Farmer, and someone else provided that. And it's, if access to health care is considered a human right, who is considered human enough to have that right? So as colleague to colleague, what's that mean to you as a physician?
Yeah, I think the question, or I think the thing that he's getting at there is, are we considering some groups of people more important than others? I work at a free clinic in South Memphis, and I love it. It's probably one of the best parts of my job. And the reason I love it is that most of the people who come in have been excluded from healthcare. They have not, they don't have the money, they don't have the insurance. A lot of folks have mental illness, and so they don't, they sort of have bad interactions with doctors because of that. And and they mistrust the medical system. And so in my mind, as I'm interacting with my patients there on Monday nights, I see how they have been considered less than human by not necessarily by individuals, but by the structural violence of our system, where you have to pay an arm and a leg in the United States to get health care. And so my question is, are we essentially saying that some people are less human than others when we refuse a basic human right? And that's what liberation theologians are saying is, no, we are all humans. We all have dignity, and we all have something to contribute to the world. And we need to make sure that everyone has that chance to do that. And so to me, it's a very pointed question and is really making us ask if there are these if there's a differential access to these resources. Are we doing that because we care less about that group of people? And I think we have to ask ourselves that question very seriously.
Thank you. Thank you again. We have one last question, but I don't know that we have the time for answering it. There's several that are coming in. I would encourage you, Dr. Dalgo, to interact through this Facebook page with these questions. We'll make certain we get them copied over there. Again, thank you so much for being with us. And to all of you who have participated with us today, next Wednesday, April 20th at 10 a.m. Eastern time, same time, Dr. Maddie Havery is going to be presenting about scarcity, justice, and the health crisis leadership. It's a great add-on to what you've started for us. Really do appreciate it. And then the following week as well is going to be about health equity, or equity and access within ethical boundaries. Again, thank you so much for being with us. And we look forward to seeing y'all again next week. Please join us on the Facebook page.